Okay, Dr. Nehal was very kind enough to prepare a small presentation, which is the frame of our discussion. And now, if we would like to start with the aged oocytes and the aged sperm and what we do in the laboratory in terms of when we have an oocyte of a patient of advanced age, should it be treated differently? And as Dr. Fauzi said, that yes, in more than one level, it seems that oocytes coming from patients of advanced maternal age, they tend to be more sensitive in physical manipulation, in deviations even of temperature. And so a more tailor-made approach should be appropriate and considered for these patients at all levels, apart from the stimulation and the overall preparation of the patient. So the same goes for the sperm. Thankfully, we do have an increased awareness for the sperm over the last years, and we do really realize that the sperm factor counts, and it can alter the destination of an oocyte to a viable embryo or a non-viable embryo. So the better prepared the man is and the better selected the sperm is, may improve the chances for a live birth. So I don't know whether Nehal wants to comment, and we can go through the questions. Nehal?
Okay. Regarding to aged sperm, it is characterized by a high rate of sperm DNA fragmentation and a high number of apoptotic sperm. At the same time, aged oocyte remarked by a low DNA repair capacity. We can use many advanced sperm selection techniques like MAX, Big Z, MZ, fine needle aspiration or testicular sperm aspiration. Frequent ejaculation may be demanded. Microfluidic chips like Zymote can be used. In your opinion, dear professors, which would add the benefit in case of advanced maternal age or advanced paternal age? Dr. Fauzi, can you give us your opinion?
Yeah, my view, if this procedure that will not be the patient will not be charged about them, we can use, in my view, microfluidic chip first and then Pixie. This is my choice. But charging the patient on this, no, I'll go for the standard, because this so far didn't proven in a well-conducted studies at a larger scale as proven successful in this category of patient, advanced maternal age. And even for the Pixie trial, as I mentioned, for over 2,300 patients in the Lancet, showed that the live birth rate is the same. Some benefit related to miscarriage, but miscarriage wasn't the primary outcome for that study, but it should be taken into consideration because advanced maternal age group also may liable to higher miscarriage rate in theory. So to summarize, microfluidic, then Pixie, in my view, if we are not charging the patient money about this procedure. If we will charge them money, I'll advise them not to use this studies, this type of sperm selection.
Is Professor Klaus with us? I would like to hear his opinion as well on this, the treatment of the sperm in the laboratory.
Thanks so much for this opportunity. So I was blessed enough while I was here. Well, I live in Seattle, Washington, and I work closely with an andrologist named Dr. Chip Mueller. And we've done some really great studies looking at effects of sperm preparation, abstinence periods on DNA fragmentation. We blinded him to all of our samples. And basically what everybody's saying is correct. frequent ejaculations is key to this, but also what we found out that using microfluidic chips like Zymote unfortunately did not improve the isolation. We actually had to go to a 4 gradient, like a Percol gradient, which just means spinning the sperm, which is counterintuitive. But what we found clearly was that when you add an extra gradient, that 4th gradient was very successful of removing more DNA fragmented sperm than just using a swim out or swim up or microfluidics. We unfortunately didn't have those same results. The other thing that we found that was really helpful was that on top of having frequent ejaculations, was that often we would use, on my end, we found that if we had the husband or the partner produce a second specimen, without doubt, the second specimen that day almost always had much lower fragmentation rates. So we would often have them ejaculate frequently leading up to those 2 weeks while the partner was in stimulation. Then we would ask for a day or 2 of abstinence. Then on the day of the egg retrieval, we would routinely ask for 2 specimens, and we almost always would use the second specimen and would have to use, like I said, a 4 gradient system in order to do that. And following what Dr. Fauci says, we also use the Pixie dish a lot. We did find that in certain patients, the use of the hyaluron binding assay while you're actually doing ICSI provided an additional sperm selection. So I agree with what everybody is saying, other than just, sometimes for us, the microfluidics didn't work. If that doesn't work for you, maybe just adding another gradient to your gradient wash, and perhaps maybe using the second ejaculate.
What is unfortunate here is that Zymote is good when you have a good population of motile spermatozoa. But let me share with you our experience. We've tried to assess DFI, DNA fragmentation, in each sample when it's raw, after gradient, after swim up, and after microfluidics. Obviously, this was limited only to the sperm with good numbers and of motile spermatozoa. And to our amazement, we found that the lower DNA fragmentation was after Zymote. And obviously, we talk about good quality sperm. And when we track the DNA fragmentation, what we saw is that even if we had recovery of DNA fragmentation, after a simple centrifugation step, the sperm structure deteriorates and goes back to high level of DNA fragmentation, which means that these men still remain less tolerant in manipulations such as centrifugation, while the microfluidics seems to treat well in selecting with these ports they use, the technology, in selecting the spermatozoa with better structured DNA. The thing is that the samples that need us the most in terms of advanced selection, we don't have other tools other than centrifugation. So this is a limitation we currently have. And can I, since Dr. Nehal mentioned FNA and TZ, would you easily move to TZ in case of advanced paternal age with very severe oligospermia, like less than 1 million, or cryptospermia, or would you still try to accumulate ejaculated spermatozoa? Dr.
Yeah.
Dr.
Fauci?
Can I
Schmidt,
comment?
this question?
Yeah, I can comment on this. For in the laboratory, I wouldn't advise. From my perspective, I wouldn't advise the clinicians or the center or the patient to go for invasive when the non-invasive is feasible. So testicular or fine needle aspiration is an invasive procedure. And to go for that invasive procedure, we should have strong data to support this. To the best of my knowledge, the data supporting this is a meta-analysis published 2017. And that meta-analysis composition having a mixed type of studies, some retrospective, some prospective, some RCTs. And that study showed that that meta-analysis showed that there is 30% increase in live birth rate with the using of testicular. I'm not going to comment on the study, but I'm going to comment on the design. Having mixed type of study decreases the evidence presented, and also having a 30% increase in live birth rate with a certain procedure in IVF. This is, as my professor, Dr. Yaqub, always said, too good to be true. So I'm not going to advise for an invasive procedure unless there is a conclusive evidence about this.
What does that mean? Do you accumulate by cryopreserving a variety, a series of samples, just make sure that you will have available spermatozoa on day of egg retrieval? I'm talking about cryptospermia. Or would you recommend...
Sorry, I may misinterpret the question. I answered that whether we are using testicular or fine needle aspiration as an option for advanced maternal age, where ejaculate is fine. This is a question or not?
Oligospermia, a severe cryptospermia.
No, just for 100% immotile sperm that can't be tested for viability in vitro, we can go for testicular. If we are able to test viability for ejaculate, whatever the number, using any method that we can use by host, by laser, or whatever, we are going to use the ejaculate.
And Dr. Klaus, what is your opinion on testicular spermatozoa over the ejaculate, when the ejaculate spermatozoa are rare to find on the low morphology or even lower motility?
I totally agree. I mean, I've had very similar experiences. You know, we've all been doing this such a long time that, you know, we all kind of come to these same conclusions independently.
Okay, thank you. Thank you.
I will add though one thing though. You know, and I see that we're talking about aged oocytes, so I'll save my comment till later.
Okay, aged oocyte, Dr. Adel.
Can we ask your question for Dr. Medhat Amer, then Dr. Sharif Gafar can answer the same question about testicular biopsy and fine needle aspiration?
Actually, whenever you find any sperm in the ejaculate, preferably to use it instead of thinking about testicular sperm extraction. And in this patient, if they are cryptospermic, it's good practice to have a cryopreserved sperm as a backup. But in my practice, when I revised my results, I found that testicular sperm were better performing than frozen cryo ejaculate in these patients. So priority is to fresh samples so long you have viable motile sperm. If not, I will go for testicular sperm extraction. And I have to keep a frozen backup, because sometimes even testicular sperm, you cannot find enough testicular sperm. You cannot find at all sperm to be injected. So if you are dealing with such difficult patient, always have the three options, and always start by the least invasive, which is the ejaculate.
I totally agree, yes.
Dear Dr. Medhat Amer, for advanced maternal age, frequent ejaculation?
Of course, frequent ejaculation is a good practice, but if the man is very old, it's very difficult to have a frequent ejaculation. A man over 60, if you ask him to have ejaculation every day, it's very hard. Also, a short abstinence is very advisable, but you need to ask the patient what is the minimal period you can have an ejaculation. Also, the idea of a second ejaculation is a good idea, but in old age, sometimes they are not able to bring a second ejaculate, and they need a long time between the first, maybe 1 day abstinence is not enough for some of these patients, but try to get the maximum because it might help in having a better semen sample, yes.
Okay, thank you, Dr. Midhat. Dr. Sharif Gafar, regarding to aged oocyte, it characterized by mitochondrial dysfunction and mitochondrial DNA point mutation, which leading to chromosomal non-disjunction during meiosis. This caused a high incidence rate of maternal age-related trisomy, such as Down syndrome. In your opinion, do you recommend PGTA from the first trial?
Thank you so much, Nihal, for the question. First, I would like to comment on the DNA fragmentation after various ways of semen preparation, because we did a study with Dr. Dalal Jazairi. I think we published it almost 6 or 7 years ago regarding the DNA fragmentation after gradient and after swim up in Egyptian patients. And we also, of course, found the same as Dr. Alexia said, that there is marked increase in DNA fragmentation comparing the fresh sample, the raw sample, and the samples after various ways of sperm preparation. So we also did this, and we have the same data in Egyptian population. Regarding the aged oocytes and PGTA, again, the problem is in the number of available embryos for biopsy. If you don't have enough embryos for biopsy, this is not cost effective nor efficient for the patient, because not only the problem of PGTA in every country, also in our country, it is too expensive as compared to the cost of a fresh new IVF cycle. PGTA cycle in our country almost cost double to triple the cost of another IVF cycle. So we should put this into consideration. If I don't have at least 5 good quality blastocysts in these patients, either from one cycle or from accumulation, I think it's not cost effective to do this invasive, expensive procedure on our patients.
Okay, thank you. Dr. Klaus, what is your opinion? In your perspective, do you prefer PGTA from the first trial? To
Yeah,
avoid...
like, part of it in our country, the United States, PGT has been very much accepted by patients. And so a lot of patients really drive PGT biopsy. And so without a doubt, almost all the patients in my experience after the age of 35, 36, somewhere right around there, almost all of them do embryo biopsy immediately, even if they don't intend to use the embryos anytime shortly. Some of the older patients, especially I've noticed some of the Microsoft executives, really love to know, like, okay, if I'm 37 years old, let me do my cycle now. Let me see how many embryos I have, and they put them in the freezer and just save them. Then we've got other patients who, again, they're going like, I've been reading about how PGTA cuts down on miscarriages. So a lot of patient social media drives the use of PGTA. And that's why we did a lot of zygote accumulation in our clinic, because we ran statistics and found that if you had, a net number of embryos, you were very likely to have a euploid embryo. Just like everybody has said, if you only have 1 or 2 embryos, the likelihood of having a euploid embryo is very low. So really, we've turned our attention to try to change the follicular stimulations. We know that often these patients that are older have luteal phase defects. And often one of the problems that we have in these patients is that they have very quick ovarian response, even though it may be a limited number of oocytes that are recruited. So one of the things that we often try to do is try to make sure that we start the patient on a low enough amount of medication with little or no previous down regulation. In fact, maybe even priming with some FSH during the previous cycle, in order to try to get an IVF stimulation that will go at least 10 days. In our clinic, we found older patients after the age of 37 were extremely sensitive to the length of the follicular stimulation in terms of how many oocytes you got, how many high quality blastocysts you got, and how many euploid embryos which would suggest that patients of older age, for a variety of reasons, require longer times for cytoplasmic and nucleic maturation to occur successfully. So I put more emphasis on trying to get that stimulation to go a little bit longer as well.
Okay,
Thank you very much. And we would like to ask if there are no further comments from Professor Fouad Abu Hamila nor Professor Hamid Youssef, we'll ask Dr. Alexia to summarize the the laboratory panel as Professor Kurt Barnell did for the clinical panel. Then we'll invite Professor Emmanuel Gindi and Professor Salah Rashid to conclude.
So thank you. Thank you, Dr. Hassan, and thank you, Klaus. I liked your comment about the cytoplasmic supplementation during the hormonal treatment. I fully agree. This is a small and very important element that we all need to consider. So for the conclusion, we all agree that more and more we need to treat patients of advanced maternal age, whether these are males or females. We do all agree that both oocytes and eggs and spermatozoa retrieved from patients of advanced age, they do have some special features. They do tend to have less more chromosomal DNA-related issues, whether it's numerical chromosomal abnormalities or structural issues such as DNA fragmentation. And this creates another frame, another set of needs for the treatment, both at the level of clinical and the level of laboratory. So there is a call to action in order to design more fitting stimulation approaches and as well as laboratory approaches for this patient population in an effort to maximize the chances for a successful outcomes. And this involves more than one level. At the level of laboratory, in particular, since this was our panel, it starts from the very beginning when eggs are retrieved at the level of manipulation and good control of the laboratory conditions where these oocytes are treated. It goes further to the processing of the spermatozoa, as these spermatozoa tend to be more sensitive. We tend to have less number available of motile and good morphology spermatozoa. So the challenge here is how to process them without further deteriorating their quality and then select them. At the level of selection of embryos, apart from the morphology, we gave a strong emphasis on PGD-A approaches and whether this is a good option to further improve the chances of our patients. And it seems that we all agree that when it comes to PGD-A, we both need quantity of embryos available to biopsy, and only in this regard it will provide a benefit to the patient, and obviously good quality of the embryos due to the invasiveness of this method. While when it's 2 or 3 or 1 embryo available, it's highly questionable whether PGD-A may offer any advantage to the overall prognosis. And we have seen clearly here the differences from country to country, where people and colleagues from Egypt raised the obvious matter of the costs, while our colleagues in USA, they really acknowledge that their patients have a deep acceptance of the method, and they're willing to proceed to the method of screening the embryos, even if they are not using it in short term. So, and I think I covered all of my notes. So it was a pleasure being with you, and hopefully our participants gained something and help them understand that we all face common issues, and by collaborating and exchanging ideas, we can improve our practices. Thank you so much for having
Excellent.
me
Thank
here.
you very much. Thank you very much, my dear friend.